Hello, Tammy and Brittany and anyone else who is watching this. This is my Barbara Budd in Connecticut with my take on application for being a regional presenter for defensible documentation. So I'm going to explain how I use the ICF way of thinking, as I like to think about it, in terms of driving my plan of care for my patients, determining what other services are beneficial in that patient's plan of care, and just the best approach to take for my patients. So when I think about the ICF way of thinking, I think looking at what are the impaired body structures. So we have thinking anatomy in that sense. So do I have impaired cardiac functions, respiratory, endocrine, whatever it is. Then that drives me to think about what are the impaired body functions. So because of this impaired structure, I have something that isn't working right, which then leads me to an activity limitation. That if I am able to determine the correct cause of that activity limitation, I will then be able to implement the correct interventions for my patient. So I'm going to start, and the way I like to explain it to people that I'm orienting is we're going to start a little bit backwards. So I look at the activity limitation and say we consider falls. So if my patient is falling, and immediately, a lot of times, especially the assisted livings will ask for a physical therapy eval. But if I go in as the nurse and I do an evaluation and I determine that the patient has fallen because they are malnourished, because they are not been able to swallow their diet, and so therefore they are just feeling weak and they're malnourished, more appropriate intervention at that point would be getting speech therapy involved to correct their diet and modify their swallowing and improve their strength before we put physical therapy in to increase their endurance and improve their safety. So let's go back to that activity limitation of falls. Say I go out and I determine that the patient is orthostatic and their blood pressure is dropping. The most appropriate intervention at that point would be doing fall prevention interventions from a nursing standpoint, maybe medication evaluation and changes, assessing hydration, teaching them the different exercises and interventions that will prevent them from having such a significant change in their blood pressure. So I would want to take that nursing approach before we really put therapy in, physical therapy in a more aggressive way at the beginning, because if we don't control their blood pressure, then they're going to continue falling anyway. What if we consider that they're falling because they can't see, they're tripping over their chairs or they're tripping over other people's walkers? Well, we need to get OT in there as to do environmental modification and to approach this from a low vision perspective before we are going to really make them safer. So that activity limitation of that safety at home and that patient falling is really can vary. And if we don't have the ability to have that ICF way of thinking of considering what is the impaired body structure and what is the impaired body function, then I don't accurately implement the correct interventions for my patient. So, I don't know. This is kind of like the approach I like to take. I encourage people to think this way in all their visits, so that we're not just going in and doing something very routinely or very the same in every visit. We might have the same activity limitation in 5 patients, that's driven by very, very different things, and we need to be able to assess that. So I don't know. That's my little take on it, and I hope you would be able to. I do love to teach. I love this way of thinking. It's helped me be better as a nurse. I love explaining to people. I love seeing them being able to implement it and feel more confident, and then to see that reflected in their documentation when they are being able to really identify what that correct cause and effect is. And I love to travel, so I hope you would consider me. Thank you.